Welcome to the start of a long talk about anemia, starting with conditions that lead to smaller than normal red blood cells. Microcytic anemia, in other words. Later, we'll move on to the anemias with normal-sized RBCs, and then, you guessed it, larger than normal RBCs. Get excited! The causes of microcytic anemia can be remembered with the acronym TAILS, TAILS, which stands for thalassemia, anemia of chronic disease, iron deficiency, lead, and sideroblastic anemia. In this scene, it's all about that first T, the thalassemias, as we recount the tales of Marco Polo, known at Sketchy as Micro Polo. In the late 1200s, Italian merchant Marco Polo spent 24 years with his dad and uncle exploring and trading along the Silk Road of Asia, traveling as far as Japan. According to Marco, the trip included bandits, sandstorms, shipwrecks, and set a new bar for father-son bonding adventures. The whole 20-year trip culminated in a meeting with Kublai Khan, the Mongolian-born grandson of Genghis Khan, and the first Yuan emperor of China. Probably a good friend to have when you're a funny-looking Italian dude trading goods in occupied China. All right, before we jump into thalassemias, let's go over a few features of microcytic anemia in general. A low hemoglobin and hematocrit level means anemia, but to classify a microcytic anemia, you've got to look at mean corpuscular volume, or MCV, which reports the average size of RBCs in circulation. If the MCV is less than 80 femtoliters, now we're micro. Just look at how microcytic those tiny teacups are. Not only that, we've incorporated a less than 80 into the teapot. See? The thing you need to remember about microcytic anemias is that what we're usually dealing with here is a problem with production of enough hemoglobin. However, when the body senses that RBCs are low and tries to tell your bone marrow to increase production, your bone marrow just can't. So the reticulocyte count, which reports how many new immature red blood cells are getting pumped out of the marrow, will stay in the normal range, even though it should be elevated as the body attempts to make more red blood cells. The retic count stays under 3%, hence the little less than 3 symbol we've included on the tea bag. Or maybe that's a heart. Special friendship tea for Marco, maybe? We've chosen a tea bag because reticulocytes contain that characteristic net-like chromatin, as opposed to mature RBCs which have no nucleus, hence the purple net-like tea bag. Plus, a tea bag is like immature tea, you know? You gotta steep it first. Anyways, how about when you look at the RBCs directly, under the microscope? Well, hemoglobin normally makes up about 35% of the volume of a normal red blood cell. But we're having a problem with hemoglobin production, remember? So when hemoglobin is low, RBCs look smaller and paler than normal. We call these features microcytosis and hypochromasia, as depicted by the small and pale teacups. While you're looking at that blood smear, keep your eyes peeled for target cells as well. These small RBCs look like bullseyes, with a dark middle, a ring of pallor, and then a darker outermost edge, kind of like these saucers. They look this way because microcytic blood cells have way too much cell membrane compared to their small volume. As a result, the extra saggy cell membrane folds over on itself and forms dark rings where they're all scrunched up. Okay, now that you know all the important features of microcytic anemia, let's talk about the T in TAILS, thalassemia. Take a look at this thalassemia, chaliceemia. Thalassemias are caused by dysfunctional hemoglobin production. And because a normal hemoglobin is made up of 2 alpha and 2 beta subunits, the handles of this chalice are alpha and beta shaped. As the rest of the illustration progresses, we'll show alpha thalassemia on the left side of the scene, when alpha globins aren't made correctly, and then beta thalassemias on the right side of the scene, when beta globins are having trouble. See the subtle 16 shape on Kublai's flag? Alpha globin chains are encoded on chromosome 16, and you get 2 from each parent, like the 2 alpha beads on each of Kublai's beard strands. That's 4 alleles total. Therefore, alpha thalassemia can have anywhere from 1 to 4 deletions. As you know, Kublai's empire extended deep into South Asia territory. And it's by no small coincidence that, as a group, alpha thalassemias are more common in Southeast Asia and, to a lesser degree, sub-Saharan Africa. Beta globin chains are encoded on chromosome 11, as highlighted by the 11 we incorporated into Marco's Italian flag. This time you only get 1 gene from each parent, so only 2 alleles, and thus 2 forms of disease, depending on whether one or both alleles are mutated. Beta thalassemias are more common in Greek, Italian, and African individuals, so it's only fitting that later on in the video, we illustrate the beta thalassemias around this Mediterranean merchant. But first, let's focus on that alpha thalassemia side. There's a potential for up to 4 alleles to be messed up here, remember? So that makes 4 forms of alpha thalassemia. The more alleles missing, the worse the disease. A person who carries just one alpha deletion is known as a silent carrier, unless you're of canine inclination. Then you're usually called something cliche like Lucky or Eileen or Lefty Lord Nelson. For humans, 1 out of 4 alpha alleles missing is called alpha thalassemia minima, and it is not associated with anemia, hence the whole silent carrier thing. You might see a couple of target cells on peripheral smear, but unless you sequence out the actual hemoglobin genes of the patient, you won't find any other evidence of disease in these silent carriers. Yep, this dog is happy as can be. The 3 normally functioning copies of the alpha subunit gene make up for the 1 missing copy, and hemoglobin production can keep up with demand. You just gotta prop your center of gravity a little bit differently. But it's all good. How about 2 alpha subunit deletions, though? This is called alpha thalassemia trait. It's also sometimes known as alpha thalassemia minor. Unlike silent carriers, these patients will actually have anemia. However, the anemia is relatively mild. With 2 deletions spread over 4 possible alpha subunit genes, alpha thalassemia trait can come in cis or trans configurations. Check out this dude's stately beard strands. If there's 1 deletion on each of 2 chromosomes, that's called a trans configuration. Trans configuration is more common in people of African descent. If both deletions are on the same chromosome, that's a cis configuration. Just think of Kublai Khan's cis twin sisters. Cis configuration is more common in Southeast Asia. Cis configuration also tends to be a bit less severe than trans alpha thalassemia trait. The classic finding in alpha thalassemia trait is a decreased hemoglobin level with an increased RBC count. What? The cause of this increased RBC count is unknown, but we're showing it anyways, symbolized by this polycythemic bowl of leche being presented to the Westerners. Leche is pale pink and no larger than cherries, so remember that the peripheral blood smear will show the usual microcytic anemia stuff, including a bunch of microcytic hypochromic RBCs. In either configuration, the hemoglobin gel electrophoresis of alpha thalassemia trait is normal, because the eventual hemoglobin multimer that gets created by these gene products is still made up of the normal 2 alpha subunits and 2 beta subunits. The problem instead is that you just don't make quite enough hemoglobin. So, normal construction of hemoglobin, just less supply for your RBCs. Patients with alpha thalassemia trait are typically asymptomatic and don't require treatment. However, screening for this condition can be a consideration for family planning in populations where the condition is highly prevalent. Okay, now for the fun stuff. Once we get past 2 alpha subunit deletions, significant clinical findings start to rear their Mongolian head. 3 alpha subunit deletions is called hemoglobin H disease, aka alpha thalassemia intermedia. With 3 deletions, there just isn't enough alpha subunit to go around, and things start to get worrisome. Erythrocyte progenitors are unable to make enough alpha subunits for hemoglobin. So in addition to the normal alpha-beta pairing, the excess unpaired beta subunits start to join up and form tetramers. See this H-shaped weapon Kublai is packing? Just in case this greeting party goes awry? It's composed of a tetramer of betas. These beta tetramers are called hemoglobin H. By the way, whenever we want to highlight the production of a new type of hemoglobin, not made of the usual 2 alpha and 2 beta subunits, in other words, we'll include these globin wheels. Hemoglobin H has a much stronger hold on oxygen than normal hemoglobin. It just doesn't like to let go, making it virtually useless in oxygen delivery to tissues. Luckily, we can diagnose hemoglobin H disease by electrophoresis because hemoglobin H migrates faster than the normal adult hemoglobin A1, as fast as a well-trained Mongol cavalry. So on the gel, look for an extra band that has migrated further than the others. Hemoglobin H is also less soluble and less stable than normal hemoglobin, so it's much more prone to precipitation inside an RBC. When this happens, the precipitated HBH forms inclusion bodies in the cytosol, represented here by the black leche seeds. These inclusion bodies damage the cell membrane and cause a chronic hemolytic anemia. Notice that not only are the lachae rupturing open, they're also contained in that spleen-shaped cage. This is to remind you of extravascular hemolysis specifically, when damaged RBCs are gobbled up by macrophages in the spleen. Don't worry, all the extra lab findings that pop up in the setting of hemolysis will be covered in our extravascular hemolysis sketch. For now, just remember to expect all of the usual microcytic anemia findings, including microcytic hypochromic cells and target cells on peripheral smear. The anemia is usually moderate to severe, and clinical symptoms are likely, but patients are not usually dependent on blood transfusions. All right, let's move on to our last alpha thalassemia. Alpha thalassemia major. As the name entails, this one is a major problem. This occurs when both parents donate 2 deletions, resulting in a child with deletions in all 4 alpha subunit genes. That means no alpha subunits are made, which is really bad because fetal hemoglobin requires 2 alphas to pair with 2 gammas before adult hemoglobin can be made. So in order for the fetus to continue making hemoglobin, 4 gamma subunits group together to form a tetramer that we call hemoglobin BARTs, just like the 4 gammas running down the shirt of this girl pulling the BARTs cart. Hemoglobin BARTs is supremely greedy with its oxygen, with 100 times the oxygen affinity of normal hemoglobin. As a result, it is absolutely useless in oxygen delivery to tissues. It just latches on and doesn't let go. Additionally, just like hemoglobin H, BARTs is also super unstable and will precipitate out, damaging the RBC membrane and causing hemolysis. As a result, the fetus develops severe hypoxia and high-output heart failure in its attempt to deliver adequate amounts of O2. The significantly elevated cardiac output pushes a lot of fluid out of those delicate fetal blood vessels, leading to a massive total body edema in utero that we call hydrops fetalis. Hydrops can also be seen in other severe forms of anemia, as we'll discuss in later sketches. Unfortunately, fetuses with hemoglobin Bart's disease rarely survive past the 2nd trimester. And even if they do survive, death is certain to occur within the first few hours. Well, that's about as bad as it gets with the alpha thalassemias. Let's move on to beta thalassemias. Recall that the beta thalassemias are more common in Greek, Italian, and African individuals. So let's introduce a few of Marco Polo's Mediterranean travel companions. Like alpha thalassemia, the severity of beta thalassemia depends on the number of beta subunit deletions. However, there are only 2 possibilities this time around. Only 2 alleles to mess with. Don't let that fool you, though. Instead of mere deletions, the genetic defects in beta thalassemia can include variable levels of dysfunction. One possible mutation is an mRNA splicing defect, represented by these spliced spices. This leads to fewer hemoglobin subunits being made. We've drawn in a variety of spices to remind you that there are multiple splicing defects that can occur, each affecting hemoglobin production to a varying degree. Alternatively, you can throw a stop codon into that beta allele, effectively deleting the gene and all of its production. Stop codons are symbolized by these corked-off codon bottles. All right, check out this guy's dysfunctional ponytail. Only 1 beta allele is defective. This is called beta thalassemia minor, when the number of beta subunits produced is decreased, but not absent. The resulting anemia is mild and doesn't cause any clinical symptoms. On lab testing, as you might expect, you'll see the usual microcytic anemia stuff, including microcytic hypochromic cells and target cells on peripheral smear. Usually not a big deal. But let's look at a few of the lab findings. When beta subunits are not formed correctly, the body has trouble producing enough of your standard hemoglobin. Remember, adult hemoglobin is mostly the A1 variety, composed of 2 alpha subunits and 2 beta subunits. In the setting of beta thalassemia, beta subunit production lags, and extra alpha subunits start to accumulate. These alpha subunits are poorly soluble, so they clump together and precipitate out of solution to form inclusion bodies. So, yet again, we've got some precipitating fruit pits to contend with. This time it's cherry pits, inside the cherries brought over by Marco Polo from Europe. This whole inclusion body business is similar to the process seen in hemoglobin H and Bart's disease. However, unlike last time, when it was the abnormal hemoglobin H or hemoglobin Bart's accumulating, in this case, it's all those extra unpaired alphas hanging around, hence all the discarded alpha-shaped cherry stems. These inclusion bodies damage the immature red blood cell membranes, and these cells are eventually gobbled up by the spleen. As you know by now, That spleen-shaped cage is our recurring symbol for splenic macrophages sequestering and breaking down damaged red blood cells. Cell death in the spleen is called extravascular hemolysis, and we'll cover it in more detail later in the chapter. In beta thalassemia, hemoglobin electrophoresis will show lower levels of hemoglobin A1. Remember, that's hemoglobin comprised of 2 alpha subunits and 2 beta subunits. Because there aren't as many beta subunits, the extra alpha subunits pair up with delta and gamma subunits, forming more of the HbA2 and HbF forms of hemoglobins respectively. This is reflected in the hemoglobin electrophoresis results, with increased thickness of the HbA2 and HbF bands. Notice that we've included 2 adults for that new A2 band, as well as a sleeping baby, for the small fetal hemoglobin band that shows up as well. All right, time to turn it up a notch. What if both beta alleles are mutated instead of just one? This is called beta thalassemia major. Sounds bad, right? Well, what you might not expect is that when both genes have only mild splicing defects, as opposed to full-on deletions, we call that beta thalassemia intermedia. 2 splicing defects represented by this guy grabbing spice bags with both arms. Clinically, the severity of beta thalassemia intermedia lies somewhere in between the beta thalassemia minor and major. So not as bad as, let's say, an abnormal stop codon on each allele. See how both beta beads are popping right off? In this form of beta thalassemia major, there is a complete deficiency of beta subunits, leading to a serious life-threatening condition. However, unlike hemoglobin Bart's, which was illustrated over on the alpha side, beta thalassemia major is not lethal in utero. Why is that? Well, babies start out with mostly fetal hemoglobin, which doesn't require beta subunits. So no beta, no worries. That is, until you reach about 6 months of age, when production of fetal hemoglobin stops. Since there are no beta subunits available to make adult hemoglobin, severe anemia develops. Inclusion bodies full of alpha tetramers damage RBC membranes, leading to profound extravascular hemolysis. All that stuff we talked about earlier. The resulting anemia is severe enough that patients with beta thalassemia major are often dependent on blood transfusions. In beta thalassemia major, the chronic hypoxemia from insufficient hemoglobin stimulates the release of erythropoietin from the kidneys, which stimulates the production of reticulocytes from bone marrow. Over time, though, with severe chronic anemia, all that erythropoietin causes hyperplasia of erythroid precursors outside of the bone marrow. Think of it this way: you need more marrow. Hyperplasia occurs mostly in the liver and the red pulp of the spleen, and manifests clinically as hepatosplenomegaly, as depicted in this fine Italian cowhide. Likewise, chronic severe anemia eventually causes so much hyperplasia in the bone marrow that it expands out of the medulla and invades into the cortex of bones. In the biz, we call that extramedullary hematopoiesis. Bone marrow invasion of the bony cortex leads to growth retardation in children from damage to the growth plates and widening of bones. A stereotypical location where this happens is in the facial bones. See how expanded and bulgy the cheeks are on that helmet? This exam finding is called chipmunk facies. With extramedullary hematopoietic expansion into the cortex of the skull, a crew-cut appearance appears on X-ray. For the power nerds, this is called parodic hyperosteosis. For more casual nerds, here's a fun fact. Anthropologists have observed these same changes in Paleolithic human skulls and long bones. If these findings were caused by thalassemia, then the thalassemias are among the oldest known human diseases. In beta thalassemia major, the peripheral blood smear will be grossly abnormal. You should be able to recite this from memory by now, but you'll see microcytic hypochromic RBCs, maybe some target cells, and don't forget about those inclusion bodies. In beta thalassemia major, the peripheral blood smear will show profound hypochromic microcytic anemia with some bizarre red blood cell morphology. The abnormal red blood cell morphology, also called poikilocytosis, will include microcytes and target cells like we've seen with the other thalassemias, but also other weird shapes, like even teardrop cells. We've included these extra weird teardrop shapes into the Paisley pattern on Micropolo's undergarments. With a total absence of beta subunits, no hemoglobin A1 can be made, and consequently, hemoglobin electrophoresis will only produce bands correlating to fetal hemoglobin and hemoglobin A2. Notice that we've drawn in 2 adults for the A2 band, as well as a happy elevated baby to embody that prominent fetal hemoglobin band you'll see on the gel. Aw, looks like we've got a little Marco Polo in the making. playing with his dad's compass. As this A shape falls to the floor, let it remind you of a complete absence of that A1 band. Iron overload, embodied by our recurring iron trapezoid weight, is a common concern for patients with beta thalassemia major. While the primary reason for iron overload is due to the multiple transfusions these patients must receive on a regular basis, the story has become complicated by the observation that even patients with beta thalassemia who do not receive frequent transfusions can also develop iron overload. The current thinking is that high rates of erythropoiesis and RBC hemolysis leads to low levels of hepcidin and therefore increased iron uptake. Check out our next sketch on iron deficiency for more info on hepcidin. Either way, serum iron and ferritin levels increase. Hemochromatosis can affect the heart, liver, and endocrine system, all of which we covered in our hemochromatosis sketch. A well-known and feared complication of severe anemias, such as beta thalassemia major, is aplastic crisis. Aplastic crisis is a total or near-total failure of bone marrow to make reticulocytes. No reticulocytes, no RBCs, and no RBCs is no bueno. To represent aplastic bone marrow, we always sketch in a hollow, lifeless plastic bone. In this scene, a new plastic chew toy for Kublay's dog. Remember from Sketchy Micro that aplastic crisis can happen in patients with a hemolytic pathology when they're infected with parvovirus B19. The aplastic anemia associated with parvovirus infection in normal children is relatively mild due to the self-limited nature of the disease and the normal 120-day lifespan of RBCs. In kids with beta thalassemia major, however, aplastic crisis is a true crisis. That's because the average lifespan of an RBC in beta thalassemia is around 5 days. When the bone marrow just stops working, that means you're losing 20% of your oxygen carrying ability every day. Aplastic crisis requires lots of transfusions to keep RBC counts up until the bone marrow starts working again. Without intervention, most children with beta thalassemia major will die by age 5. Treatment requires chronic RBC transfusions. Sometimes patients can receive a bone marrow transplant, which is curative because the new bone marrow is able to produce normal hemoglobin. Before we go, you might have a couple of questions. Like, if these mutations are so bad, why do so many people still carry them after hundreds of thousands of years? And why is thalassemia always endemic in warm places? And what about that badass double beard braid? I mean, do you shampoo it? Or is there some kind of cleansing spray or something? Well, in the 1880s, a bunch of really smart people asked the same thing. And the answer, as it turns out, is probably mosquitoes. Specifically, it has to do with the protozoan Plasmodium falciparum. Remember that name from Sketchy Micro? Several hemoglobinopathies and RBC membrane disorders are more common in areas with higher rates of malaria infections. Epidemiologic studies have convincingly illustrated that these disorders actually confer some level of protection against malaria. The exact mechanism, however, is still anyone's guess. These disorders probably make the RBC more prone to lysis. And when the Plasmodium parasites invade and multiply within the RBC, the extra oxidative stress they cause is too much and the cell dies, killing the parasites with it. In the end, thalassemia and the 2 other anemias we'll cover later offers people protection from malaria, at the cost of lifelong anemia. This includes aberrant alpha allele carriers and beta allele carriers, as represented by the protective mosquito netting shrouds.